Good morning, ladies and gentlemen. Welcome to the next symposium. Our first speaker is Dr. Navoda Atapattu, the first consultant pediatric endocrinologist, currently working at Lady Ridgeway Hospital. Over to you, Navoda.
Thank you very much for these kind words of introduction, as well as the organization inviting me to talk to you on childhood diabetes care, Sri Lanka. Bit of introduction, as you all know, it is a metabolic disease of carbohydrate metabolism characterized by persistent hyperglycemia due to defects in insulin secretion, its action, or combination. The diabetes is increasing incidence and prevalence over the last 40 years. Type 1 is the commonest form, resulting from autoimmune destruction of pancreatic beta cells. Type 2, monogenic diabetes and other forms also contribute for this increasing incidence and prevalence, even though still in pediatric population, type 1 is the commonest. These are the global estimates. According to the global population in 2021, type 1 diabetes is number of prevalent cases of type 1 diabetes is close to 651,000. And type 1 diabetes in children and adolescents up to 0 to 19 years, it comes to about 149,500. So this is the disease burden according to the IDF Diabetes Atlas in 2021. Age and sex standardized incidence rates of type 1 diabetes, 0 to 14 years. According to this atlas, the numbers are very high. However, we don't have data in this map because Sri Lankan data is not available with regard to incident rates. So, even though we don't have the numbers, let me talk to you about these categories. Type diabetes-related autoantibodies, how the predicting the occurrence in siblings, thyroid autoantibodies, celiac disease, vitamin D and diabetes, how we manage them, what is the psychological aspect. These are the things that we have done for the care of patients with type 1 diabetes and also children with diabetes. It is managing a child and a family with a child with diabetes is an art, but it is challenging and also interesting. So let's talk to you about diabetes-related autoantibodies. The prevalence of diabetes-related antibodies in children with type 1 diabetes and their siblings. This was made possible by a WHO second health sector project grant with collaboration of a UK laboratory. So antibodies to islet cell antigens are a hallmark of type 1 diabetes, and those are directed against 65 kilodalton isoform of glutamic acid decarboxylase, insulin, insulinoma-associated antigen, and zinc transporter 8. So the justification for this was to see the antibody prevalence of children in Sri Lanka with type 1 diabetes, and determining the commonest antibody type, which will help us to decide on the initial screening. And also, it can help the determining the antibody prevalence of siblings of affected children, because when you have a child, person with diabetes, the sibling has a higher risk of getting type 1 diabetes, 2 to 3%. And also, we can look for the feasibility of cost-effectiveness way of finding doing the community screening in future, even though there are no preventive measures at the moment, but it is good to know what type of antibodies are prevalent and what is the prevalence rate of positive antibodies in our community. All new and previously diagnosed children of both sexes and their affected siblings were recruited for the study, and those were identified from the registry maintained at Lady Ridgeway Hospital. However, we excluded the patients following diabetes following immunosuppressive treatment, secondary diabetes, maturity onset diabetes of young, if known or suspected, were excluded. And we got the approval from the Ethics Review Committee of College of Pediatricians. So this is my recruitment. We had patients, 300 patients consented. But at the end, we had only 235 for the analysis. And also, we had 252 siblings. So we took venous samples from the subjects and centrifuge immediately and froze it at -80. And these samples were transported in dry ice to FIRS laboratory in Cardiff. Samples were analyzed using a common 3-screen method, and also individual antibodies were assessed using ELISA. So this is the results. The median age of the affected subjects was 8 years. Median age at sampling was 11 years for the subjects and 9 years and 10 months for the siblings. Median duration of diabetes was 23 months, and male-female ratio was almost the same. So when you look at the antibody prevalence, 3-screen was positive in 79.1% of patients. And when you consider the siblings, 6.3% were positive for 3-screen. That is a combination of antibody screening. Then we checked the individual antibodies. GAD antibody was the most prevalent antibody positive in this cohort, which was 74%. Insulin IA2A antibody was positive in 31%, and zinc transporter 8 antibody was positive in 38.7% of patients with type 1 diabetes. And in siblings, 2.4%, 6% were positive with GAD antibody, 2.4% was positive with IA2A antibody, and 1.6% was positive with ZNT8. And the prevalence of single autoantibodies in 3-screen as a negative subjects was 3%. We had few negative patients, probably because of the sample handling. And when we consider the disease duration and the prevalence of antibody-related autoantibodies, GAD antibody remained almost static, and with time, IA2A and ZNT8 antibody prevalence came down. So this is the distribution. We had 72, which means 30.6% of patients had only GAD antibody positive. 6 patients, that is 2.6%, had only IA2A positive, and 5 patients had only ZNT8 positive. And all 3 antibodies were positive in 18.3%, and 2 antibodies was positive in 16.6, 8.5, and 1.7. When you consider the distribution of antibody-related, type 1-related antibodies in healthy siblings, 3-screen was positive in 16 siblings. As we heard yesterday, one antibody positivity does increase the risk of getting diabetes in 50%. And if you have more than 2 antibodies positive, the risk of developing diabetes is more than 90%. So we had 4 patients who had 2 antibodies positive. Out of those 4, 1 patient developed diabetes within 1 year, and then other patient developed diabetes together with COVID-19 infection, and other 2 are on follow-up. These were all consented patients, because we know that at the moment, knowing the risk does not help us to prevent developing diabetes at the moment. Using the same samples, we looked at the thyroid autoantibodies. TPO antibody was positive in 28% of patients, and 100% of them had hypothyroidism. Thyroglobulin antibody was present in 78% of patients. So this work was published in Frontiers in Endocrinology this year. Celiac disease. In Asian countries, people think the celiac disease is not seen, and even though the guidelines suggest that the celiac screening has to be done at the beginning of the diagnosis, we do not have the facilities. So it is recommended to do it at diagnosis. So we did a descriptive analysis at the clinic using the serologically confirmed type 1 diabetes. We could use only 56 patients. Out of them, 29 were females. Because of the inability to spend money on these screening assays, we could only limit this study for 56 patients. Out of them, 2 patients were confirmed to have celiac disease, and out of them, 1 patient at the moment is a very good table tennis player who is a rank table tennis player of the country, under 11 team. So this is the publication. And why it is challenging? Because our country thinks the celiac disease is not common, so gluten-free food is, we don't have, the industry is not interested in making gluten-free food. And very few imported gluten-free items are available. So these prevalence studies will help us to make the people understand that it is necessary for us to have a gluten-free area in the supermarket. Vitamin D and type 1 diabetes, even though the diabetes is prevalent in areas closer to the polar regions, where vitamin D is common, we wanted to look at whether the vitamin D deficiency is common in children with type 1 diabetes. We checked the vitamin D levels, and also the dietary vitamin D intake was obtained from the 3-day dietary recall. And this is how we check the average body surface area which exposed to the sun. We used the rule of palm method. And we had 38 patients. 16 patients had vitamin D deficiency, and there was no significant difference in average sun exposure in patients with vitamin D deficient and sufficient groups. And as you know, dietary vitamin D intake was lower than the recommended daily intake in 84.6% of these patients, and this was published in Commonwealth Gastroenterology Nutrition Management Protocol. Management in low resource settings. Yes, we are a low resource setting, and we know that the intensive management reduces the long-term morbidity, and it includes multiple daily injections with appropriate carbohydrate counting, self-monitoring of blood glucose, and patient-centered diabetes education. This is where the world is going, and where are we now? So until 2011, children with diabetes were managed with conventional insulin therapy, and the necessity to start intensive treatment was felt with increasing numbers, but we did not have material for carbohydrate counting or insulin analogs, and most patients did not have the facilities to do self-monitoring of blood glucose. So a special approval was obtained to purchase insulin, pens, needles, and glucometers from the Ministry of Health, and then carbohydrate counting, which was the backbone of the glycemic control. We prepared a book which includes the different food items with the photographs, and portion sizes were included together with the calorie values and the carbohydrate. And the nutrient information was obtained from USDA food composition tables. And this book was out in 2014. And these are the pictures of the carbohydrate counting book, some of the pictures. And ever since, every year we did practical sessions with patients and families. And for this, almost all of my trainees helped with preparing food items. And this was an annual event until 2019. When the pandemic hit, we could not gather. And after that, we were hit by a big economic crisis, and probably from this year, we should be able to start this again. Psychological aspect. It is a psychological challenge for affected family, and child who stays after school will have to think about this insulin, meals, and blood sugar monitoring all the time. So these continuous reminders of the disease make them more vulnerable to psychological disturbances. So we did an assessment of psychological status of children with type 1 diabetes under these 7 areas, and noticed that 13% of the boys and 22% of the girls were affected psychologically. And next is my favorite topic, neonatal diabetes. It is a rare form of diabetes, but an interesting area to diagnose. Present with hyperglycemia and failure to thrive during the first 6 months of life. There are 2 types, transient and permanent. And these molecular genetic tests help us to determine the treatment options. And with the help of Exeter Genetic Laboratory, these are the genetics of our 23 patients with neonatal diabetes. First 3 were transient, and we had 1 GCK mutation, 6 patients with KCNJ11 mutation, 7 responded to glibenclamide. We had 4 patients with ABCC8 mutation, 3 responded to glibenclamide. 3 patients with INS mutation, all 3 are on insulin. FOXP3, we have 2 patients and 1 died due to nephrotic complications. We have 2 patients with Walcott-Rallison syndrome, 1 died due to severe liver failure. 6P24 is off treatment now. 1 patient with AIR mutation, he has trisomy 21. And most recently diagnosed patients with PTF1A mutation passed away due to severe sepsis. The patient had diabetes and failure to thrive together with malabsorption. Passed away due to severe sepsis, and unfortunately, even before we received the genetic studies. So how do we improve our services? Children need continuous follow-up, and it should not be a hindrance to their day-to-day activities. And they need a lot of care, attention at all stages and all events in life. And they require repetition of clinical advice as well as adaptations to various circumstances. We prepared written information in our local language, and these information leaflets are given to all the patients. With the advancement of technology, we also wanted to be a little bit high-tech people. So we changed the food guide book to an app. Now patients can download this and look at the food guide book through an app. And also all the medical advices were recorded into small clips and put that in the YouTube. So they can type Diabetologist Sahalamaviya in Sinhala and you get that green icon. And when they click on that, they will get about 10-15 small video clips where they can listen to. Each video clip is about 8 to 10 duration. So whenever they feel like listening to these advices that we used to give at the clinics can be listened to over and over again while they are at home. So this was handy for those patients. Next is the patient support group. And this is a government-registered support group for parents of children with diabetes. And this logo was prepared by one of my children with diabetes. This is registered for the last 2 years. And we need to do transition. So we inaugurated our first ever adolescent transition clinic in 2020 at Kothalawala Defense University with a physician, adult endocrinologist, pediatrician, and a psychologist. And I'm sure my other colleague who is working in Kandy area will very soon start the adolescent transition clinic for patients with diabetes in the Hill Country. And this provides continuity of care and minimize the loss of patients during follow-up. And patients we generally introduce to the team at KDU and seeing the familiar person, whether they like it or not, after them since childhood, who looked after them since childhood, it was very easier for them to adjust to the new settings. So I had to go there once a month and work together with my adult colleagues as well as the psychologist and the pediatrician. Unfortunately, they had to see the same person over and over again, even though they were more than 18 years. They couldn't escape from a pediatric endocrinologist during the transition clinic. So in conclusion, all these we, on our part, were to improve the status of care of children with diabetes from diagnosis to management and from genetics to etiology. But we have a lot more to do. We need newer insulin delivery systems such as insulin pumps and continuous glucose monitoring systems. This is, we do have patients who are on flash drive Libre, freestyle Libre monitoring systems, but only a minority of patients, only 12 patients. That depends on how much they can spend for their diabetes care. But we need this to be given to all patients with diabetes. And it should not be, it should be made, we have to make it a notifiable disease so that we can capture data on prevalence and incidence. And we have to make facilities to detect celiac disease, which has to be made available free of charge and at a low cost so that we can screen them at diagnosis as well as every 2 to 3 years. We have to facilitate appropriate care in schools. Still, our school teachers are not geared to look after these children with diabetes, and they need a lot of support at school. We do not have community nurses or social workers looking after children with diabetes. These are the areas that we have to develop. We need more psychological follow-up sessions and the epidemiological data to see why type 1 diabetes is increasing in Sri Lanka. And I think we could fill these gaps in diagnosis and management of children with diabetes in very near future when I see our trainees coming back to work in this country. This is a lovely country to work in. And I think all of you, and thank you very much for my team for the continuous support that they have given during the carb counting sessions and also looking after these patients. And thank you very much for the person who have come back to work in this country. And thank you in advance for those who are planning to come to the country to work together, because we have a few barriers to overcome. I hope together we can do this. It is in the very near future. So thank you very much for your attention.
Thank you, Navoda, for that excellent presentation. I think she has changed the management of type 1 diabetes in Sri Lanka after she started working at Lady Ridgeway Hospital. She has done a massive work, and also research and the presentations. I think for young doctors in this forum, I think a good example.
Yeah, we'll move on to the next talk of the symposium. He's Professor Nick Oliver. He's a consultant diabetologist in Imperial College, United Kingdom. He's a professor of metabolism, and he will talk about transitional care of type 1 diabetes. Over to you, Professor.
Thank you very much. And hopefully my talk follows on chronologically in the life of children and moves into transition and tries to describe some of that experience. In putting this talk together, it became immediately apparent to me that actually I can't give you very much evidence or data. So a lot of this is my experience and the experience of my colleagues and what we do in the United Kingdom, but is hopefully of interest and delighted to discuss later. These are my declarations of interest. So I think the first thing to do is to define exactly what transition care is. I don't think there's an agreed definition, but the definition that I'm going to use today is that transition is the planned transfer of care from paediatric diabetes care team to adult services. So if you start wholly within a paediatric service and end up wholly within an adult service, the bit in between is transition. And it usually occurs somewhere between the ages of about 16 and about 23. And I'm very loose about that, because it's very much guided by the emerging adult that we have in our clinics and by their parents and carers and by their needs. So some 15-year-olds are very mature, very able to self-manage, very capable, and want to push on and be independent. And some 20-year-olds are still very dependent on parental care for their diabetes, and we have to be very adaptive to that and make sure that we understand those needs. So why do we need transition care? So these are data from the Type 1 Diabetes Exchange in the United States, and they show HbA1c values throughout the life course of people living with type 1 diabetes. And you can see that between the age of 6 and 17, the HbA1c mean, this is average HbA1c, rises from around 8% to 9% before falling very gradually over the course of the late teens and 20s to a fairly stable point at the age of around 30. And what we're trying to do in transition is manage that hump in the middle, try to minimize it, and try to minimize the burden and adverse experience that young people might have living with diabetes at that age. Previous speaker very sensibly mentioned using things like insulin pumps, continuous glucose monitoring, Freestyle Libre, and I'm very privileged to work in a system that has access to those. Interestingly, they don't really matter at transition, and the one time when people don't really want to use technology and devices is when they're an emerging adult, an adolescent or a young adult. And the same data here from the T1D exchange show that it doesn't really matter if you're just on an intensified insulin regimen with self-monitored blood glucose, or whether you're on a pump and continuous glucose monitoring, you still have the same hump, the same rise in glucose, the same challenges, and the same return to baseline afterwards. It just starts from a slightly different baseline. So what are the challenges to successful transition? So these are some of them, and I don't propose to go through all of them, but I think some of the ones to highlight I will talk through as we go, and it's really trying to get someone who is full-time in school, managed by and with their parents, to someone who is no longer in school, maybe living independently, and is certainly self-managing independently. And a lot of things happen there, leaving school, starting work, starting college, starting to have relationships, starting to go out independently, and all of those things are much more important to the emerging adult than living with diabetes. What this really needs then is a readiness from both the family, the carers, the parents, and the child to go through this process. One of the things that we do in transition that we don't talk about enough, I think, is that we're transitioning the parents. If you've looked after someone with type 1 diabetes for 10 years, it's very difficult to let that go. You've been the carer, you've made the insulin decisions, you've done the monitoring, you've looked after the hypoglycemia, you've worried about the nocturia, you've worried when they might not be gaining weight or eating, and to let that go can be very difficult. So it's important to remember we're not just transitioning the child as the patient, we're transitioning the parents as carers. And sometimes that is the much harder thing to do than transitioning the child. But I think this is a very nice model of how the patient moves away from the family, takes responsibility. And of course, they keep a dotted line to the family, and they keep a dotted line to everything about that, but they have to take on adulthood and self-management independently. So what do the guidelines say? Very little, actually. These are the ADA guidelines and standards of care for transition care, and there are 3 bullet points. And the really important thing, rather than reading them all, 2 of them are for type 1 and 1 of them is for type 2. And this talk is really focused on type 1 diabetes. But the really important thing is that they are all evidence grade E. They are all consensus opinion. They are not evidence-based. So these are non-specific ADA standards of care based on a low quality of evidence, and they're very vague. Prepare the child, deliver multidisciplinary care jointly, is really what they say. And if we look at the NICE guidance, this is NICE NG17 that was updated last year in 2022, you can see that they are all very similar. Again, they're non-specific, and they are a low quality of evidence. And NICE very helpfully show you when they first wrote that bit of guidance and whether it was changed. And you can see that all of the NICE guidance for transition was first written in 2004. So it's 19 years old. It has not been changed meaningfully. And the reason why it's 2004 is because there was not a NICE guidance before 2004. So we've had one guidance, really, on transition that hasn't changed in 19 years. So there's a huge evidence gap here. There's also, in the UK, we have a NICE document that's called Transition from Children's to Adult Services for young people using health services. And again, it's non-specific and a low quality of evidence. And there is an NHS England Diabetes Transition Service specification that was published in January 2016 and hasn't been amended or updated since then. So we're operating in a best practice, opinion and consensus arena, and that's why a lot of the slides that I'll show you today don't have references. So how do we best transition care? I think one of the most important things is planning and managing expectation for the young person, for their parents and carers, and anyone else around them. So talk to them early. Start having the conversation when they're 14 or 15. Start telling them what your local process is and what is going to happen. So when an adult physician or an adult dietitian or an adult diabetes educator comes into the room and says hello, they're not surprised. They know that this is coming, they know that they're going to meet them, and they can have a nice conversation. As I said before, transitioning the parents can sometimes be even harder, so tell the parents it's going to happen as well. Tell them that the diabetes care team will change and that transition is a holistic move that includes everybody involved towards self-management. This has to be gradual. Occasionally we get referrals from other centres that say, please can you see this 18-year-old because they're no longer a child. We do take them over, but that's not transition. That is a letter of transfer, but it is not transition. And I always feel slightly uncomfortable doing that, as I think does the 18-year-old often. So some of the things that I would consider trying to do, and some of these things can be challenging, but one of the nice things to do at the beginning is just to spend a little bit of time with the emerging adult on their own. So if they come in with a parent or carer, do the consultation and then say to the parent or carer, can I have 2 minutes with them, just the two of us? And just try and do it for 2 minutes and then 5 minutes, or call them in first and say, I'll call you in a minute, mum. And we try to do that. And we try to just spend a couple of minutes. We don't talk about diabetes. Actually, one of the things that I do in transition is never talk about diabetes, because they don't care. They don't want to have diabetes. They don't like having diabetes, and it's not interesting to them. Talk about school, college, friends, hobbies, stuff that's going on. And I don't think we should necessarily be their friend, but we should certainly try to make it clear that we are their ally. So have those conversations and try to do a little bit of the consultation with just them. And if it's just 1 minute to start with, make it 2 minutes next time, 5 minutes the time after that, until they feel comfortable coming in on their own, and mum and dad or whoever comes with them feel comfortable letting them do that and know that they're not being excluded. You have to introduce them to the adult team early, as I said, so even in just passing in the corridor, oh, hi, this is Dr. whoever, this is one of the adult doctors, you might meet them again next time. And just start to introduce them very gradually, early, and again, for very short periods of time, and then increase it. And what we started to do now is have anyone in the room. So we have a joint clinic, and I will sit with one of the paediatric educators. My adult diabetes educator will sit with the paediatric consultant, and we'll mix and match. And it can be a really helpful way for them to always have someone that they do know in the room who is safe and familiar, but there might be someone new in the room who's just there to observe and just occasionally say helpful things. One of the things we try to do is give the emerging adult a task to do themselves. So rather than saying to the whole family, I think you might want to do perhaps more insulin with breakfast, give it to the child, give it to the emerging adult. So what I want you to do, next time you have this for breakfast, I want you to really think about it. Look at them, give it to them as a task, give them, not quite homework, but give them homework, and make sure they know that it's their task. And similarly, give mum or the carer, whoever comes with them, a task to do the opposite, to step away and say, maybe at the weekend, why don't you let them do their own insulin when they're at home having lunch? Something like that. So just give them the permission and the homework and a task to step back. And if you can do that together, then you're transitioning them at home as well. You're transitioning responsibility and helping them to do that in a way that they're both comfortable with. We have to start having adult conversations sometimes at a very surprisingly young age in our North London diabetes clinic. A few years ago, we had 2 under 16-year-old boys who were under us, and the police came to us and said, these 2 boys both have diabetes. You cannot see them at the same time. They are members of rival gangs, and if they are both in the waiting room, they will have to have a fight. They will have to. They cannot look at each other. They know who each other are. They know they're in rival gangs, and because of the rules of the gang, they will have to fight each other. One of them, or both of them, might have a knife. You cannot see them together. So we have to deal with some quite adult and difficult problems sometimes. One of the things that we try to do is have early conversations about sex, drugs, and rock and roll. So we are happy to talk to them. Often this is a good one to do when the parents aren't around. talk to them about sex, talk to the girls about menstrual cycle, and that it will affect glucose. I think lots of women feel surprised that their menstrual cycle affects glucose metabolism in type 1 diabetes. Typically, premenstrually, they have rising insulin requirements up to the point when menstruation starts, where there is a sudden drop-off in insulin resistance, and often women have hypoglycemia on the first day of their menstrual period. And knowing that and being able to prepare for that as a young woman is empowering in terms of self-management. Talk about contraception early. In our clinic, 50% of our type 1 pregnancies are unplanned, which is 50% too many. We would really like all of our women to plan their pregnancy with type 1 diabetes so that they can be appropriately treated with folic acid and so that they can have a reasonable expectation of what a pregnancy living with type 1 diabetes might look like. We talk about conception and the future for fertility, because very sadly in my clinic, I still see women in their mid-30s and 40s who say that they were told that they should never have children because they have type 1 diabetes. That is not true. It's important to understand that there are risks for the mother and the fetus, but it's also important to make it clear that we can encourage and empower and enable women to have normal pregnancies with healthy children with living with type 1 diabetes, and trying to undo some of the things that they may be told is helpful. We have a realistic conversation about recreational drug use. I tell people what the effects of recreational drugs are for type 1 diabetes, and I leave them to make their own decisions. I don't think it's up to us in the UK as doctors to tell people what to do, but I do think it's up to us to make sure they're clear and understand the consequences of what they do. And similarly with alcohol, we don't tell children or young adults, emerging adults, not to drink alcohol, but we tell them how to handle alcohol so they don't have severe hypoglycemia and so they don't have ketoacidosis. We have strict European Union driving regulations. So again, we go through all of those before people can get their license at the age of 16 for a small motorbike or 17 for a car. So it's all about checking glucose and safe driving practice around management of hypoglycemia. And I'm sure you'll have some local guidance for that too. One of the things that actually is true for all ages, but I think is particularly true for young adults and emerging adults, is how we use language. So NHS England published this document called Language Matters, and it encourages us to use person-centred language for people living with diabetes. So we should never refer to people as diabetics, because it defines them as a human by their long-term condition. We shouldn't say diabetes sufferers, because it's not up to us to decide whether or not they suffer. That's their experience, and they're a person. So we talk about people living with diabetes, and I've even heard people advocating that we should be talking about people living well with diabetes. The WHO definition of health doesn't preclude you living with diabetes, so you can be a perfectly healthy person with type 1 diabetes. We should try to be non-judgmental, talk about management, not control, not talk about good and bad glucose, not attaching value judgments to any particular behaviour or level of glycemia, but talking about targets. Say, oh, your glucose is a little bit above target. That's okay. We can work together and we'll get it closer to target. And those simple things, using language that takes away judgment, takes away pejorative statements, and is encouraging and empowering, can hopefully help to work together for slightly improved outcomes. So I haven't talked at all yet about glycemia, which is supposed to be the important thing in type 1 diabetes. So I think often, as I said, I don't talk directly about glycemia. I try to talk about the things that are important for people living with type 1 diabetes. So visibility and stigma and distress around living with diabetes are really big things if you're 18 or 19 and none other of your friends and colleagues have diabetes. It makes you feel very other, and that can be very distressing and ostracizing with a really significant mood component. Devices don't help. So it's a picture there of a Freestyle Libre, and you can see that it's just a massive flag, isn't it? It's just a big, I have diabetes. Manufacturers do not make appropriately skin-toned devices, and that's something that they are told repeatedly internationally is unhelpful. So their priority might not be glycemia. And one of my colleagues has a phrase, and he says, we should roll with resistance. And I'm not sure this is always true, but if you have a young adult who is pushing back and resisting, If you start to push back on them, you're probably not going to get very far between you. So the idea is to roll with the resistance and find a compromise somewhere. Say, okay, that's no problem. I really understand that you don't want to do that. What can we do together? How can we help? So I think the other thing is about having future expectations. They must know that they'll have multidisciplinary care, that they'll have complication screening, and really importantly again, complications of type 1 diabetes are not inevitable. I still have people, adults in my clinic, who say, well, my legs are going to fall off at some point. No, they're not. Between us, we can make sure that doesn't happen. You don't have to have retinopathy. You don't have to be on dialysis. You don't have to have renal failure. And that's a conversation that I still have repeatedly. So encouraging and empowering messages that complications are not inevitable is important, and that you can do anything in life. I say you can have any job you want. You can fly a jumbo jet across the Atlantic full of passengers. You probably can't be an astronaut because we don't know if insulin is safe in space. And that's the only thing I say. You can do anything with type 1 diabetes, and saying that can be really important. So a quick word on treatment concordance. There are lots of words for this. Some people sort of say compliance and adherence. Compliance means that people comply with what we tell them to do, so we're not supposed to use compliance or adherence. Concordance is that we agree, we have a concord about what we're going to do, and some people will even talk about treatment readiness. Your patient is ready for your treatment, which I'm not quite sure about. But if you want a concordance with a treatment plan, make sure it's jointly reached. Reach it together, document it, share it. And that is much more likely to be successful with this group of emerging adults than telling them what to do sometimes is. A couple of tips is to consider the longest acting basal insulin you have if you perceive a DKA risk, and consider ultra rapid analogues if you can for boluses, as often this group of people will have snacks or bolus after meals, or we'll be using rapid-acting insulin for corrections. And at some point in the future, we'll start using connected pens so we can objectively look at concordance and reflect back on that with our patients. So here's some endocrinology, which is unusual for me. I don't normally do endocrinology. You all know this, but it's important to remember that puberty is a relatively insulin-resistant state. It is said that insulin resistance post-puberty gets better. Actually, I think most of our experience is that insulin requirements go up during puberty and actually don't really ever come down again because we have bigger people who have probably worse lifestyles. But it's important to remember that insulin requirements can go up really very quickly at the start of puberty. And a little bit more endocrinology. This is one of my absolute bugbears in the transition clinic. These are growth hormone profiles for young adults and older adults. The overnight growth hormone peak that we see in children does persist into adults, but it is much smaller. If you give insulin glargine at night, what you tend to see as young adults become older adults is that you have 3 a.m. hypoglycemia and you cannot titrate the basal insulin. Please, when you get to adolescence and adulthood, move the basal insulin to the morning. It's the simplest thing you can do. You will eradicate overnight hypoglycemia and you will enable yourself to titrate that basal insulin so much more effectively. The alternative is to split the basal insulin and have it twice. But if you take nothing away from the last 20 minutes, please think about doing that. So in summary, transition is hard, but it's hardest for the emerging adult. It's hard for us, but it's definitely hardest for them. Be patient, be supportive, and remember to transition the parents and carers as well, because they're the ones who might push back. Move the basal insulin to the morning. Be prepared to reduce insulin after puberty, but it doesn't always happen. And see if you can do that gradual transfer. And finally, remember that this does happen. So even if it's really hard for a couple of years, most people get on board and get it sorted. Remember that you're just trying to support them through a difficult few years, and they'll hit the slopes and come back down by the time they're 30. Thank you.
Thank you, Professor Oliver, for your wonderful talk. And we have come to the end of the symposium. On behalf of the Sri Lanka College of Endocrinologists, we thank both speakers for their wonderful talks.